Hello and good afternoon, good evening, good morning, wherever you are in the world. Thank you very much for joining me again for another live discussion with an expert. And today we're going to be talking about the ethics of vaccination, COVID-19 vaccination in children. And this is such an important point at this stage. And it's difficult for parents, especially, to get an understanding as to what's happening. And what I have found is that often people don't want to speak about this in terms of experts. They don't want to publicly share their views. And we have the pleasure today of having with us Dr. Ros Jones. She's a retired pediatrician. And I will let you just do some introductions, Ross, before we get started into chatting a little bit more about vaccination in children. So please, Ross, just tell us a little bit about yourself.
Well, I'm a retired paediatrician. I was working at a busy district general hospital with my main interest being newborn intensive care and also infectious diseases. And I retired a few years ago. I've done since then some teaching in various countries in Africa. And then I could also say that when I was working, I was Director of Women and Children Services, and I was a bit involved in planning for the swine flu pandemic. And at the beginning of March last year, oh, not last year, God, it's 2 years ago, isn't it? In 2020, I had friends saying, oh, this is ridiculous. I survived the Asian flu. This will be fine. And I was saying, no, come on, this is serious. This is a new virus we've never met before. And if 80% of the population get infected, and even if there's only 1% deaths, that's an awful lot of deaths. And particularly if they all happen in the space of 10, 12 weeks.
And so
I was quite anxious at the beginning, and then my views gradually changed.
So this is an important point, is that you got yourself psychologically prepared for the fact that you were going to be frontline again. You could have stayed in your home and been safe. Why did you decide? Because you didn't know how severe the infection could be. You were willing to put your life on the line for this, were you?
Well, I would have done, of course. And if I'd still been working, then that would have been, gone without question. So when we were asked to go back to work, I signed up with the GMC. But at that point, obviously over 70s were being told we should stay indoors. And so initially I said, well, look, I could do anything online, maybe do 111 call handling or something. But I had interviews and CRB checks sorted. And I said, if they need me at work, I will willingly go back. Of course I will. I had visions of the children's ward filling up, my colleagues getting sick. And of course I would have gone back. But then, of course, it never happened. And I think what became very obvious early on, which is a blessing if you're a parent or a grandparent or a pediatrician, is that children were not impacted in the same way at all. And I think we knew that even from Wuhan and Italy before it got to the UK, that the average age of death from this virus is approximately, in fact, slightly older than the average age of all-cause death. So this is a disease of the elderly and frail, mainly.
I think I'd completely agree with that, Ross, because when I started looking at the research in late February, early March, I remember the first papers coming out of China. When I looked at the severe patients, there were no children. And that to me was one of the standout things. I thought, how in the world are we having a viral infection that wasn't affecting children? And there was hypertension, but not children. So I agree, it stood out that there was something that was not quite right. And so then how did your thoughts evolve as the months rolled by?
Well, I think in the first few weeks, we sat in the back garden. We went for lots of walks. It had a very surreal sort of feel to it all, I have to say. But my colleagues, the hospital, were incredibly busy. The intensive care numbers were doubling week by week, and they were spreading into the cold surgery was all cancelled and intensive care was moved into the theatres. I thought they did fantastically well. And they got to the point where the children's ward, they'd lent most of their junior staff to the adults. And I and a neighbour of ours, we were sewing scrub outfits for the consultants at Wexham in the paediatric department, so they could go and do on-call while they're juniors, for peds, while they're juniors, were all working on the adult wards. But what then became very apparent was that within weeks, they got to the point where the children's ward was going to be turned into the 5th intensive care unit, when I think they'd gone up from about 6 medical patients to about 86 over the space of a few weeks. And they only had about 5 children in the ward. I mean, it was eerily quiet. It was quite worrying. You know, diabetic children were not coming to hospital that should have done. And so they were going to put the children into the closed outpatient area and give the children's ward. But suddenly, just as mysteriously as it had all been going up, it sort of leveled off and started coming down again. And I think that's when I began to think, oh, that's great, now we'll all get back to normal. And we were told maybe the over 70s should stay indoors for 12 weeks. But I think I'd assumed that everybody else would start going back sooner. Particularly all my grandchildren were obviously sent home from school, but my daughters wouldn't let me go and help because they thought, oh, you're over 70, Mum, you need to stay indoors. So they're being very kind and protective towards me. But then they didn't go back after Easter. And then even when it came to half term, they were meant to go back. But then the Secretary of State for Education backtracked and sort of said, well, schools will have to do what they think they can, you know, leave it up to head teachers, whether they do go back or not. And so it was very variable, and some schools went back for all their kids, and some schools just didn't go back at all. And what were you... odd. And I think the other thing that was very odd, and my husband's a physician, and he was thinking, you know, every year in the winter, medical patients always crowded out the surgery, and that was understood. But within 2 or 3 weeks of the middle of the flu epidemic, as soon as beds started to free up, the surgeons would be back in there saying, oh, I need to get this emergency patient in. And 2 weeks later, they'd be getting their beds back. But this time round, all these surgical theatres that have been changed into intensive care units, they seem to be unable to put them back to use. They seem to be saying, oh, well, what if there's a second wave? And so a lot of that first summer, I think there was a huge delay to catch up with all the backlog in the work.
Yeah. So let me ask you.
Knock-on consequences even now, where we're seeing huge backlogs and waiting lists.
So let me ask you a question that I thought about then, and at the time people thought it was ridiculous, which was that I thought that at that time we had no vaccines or anything, barely had any steroids, and I said that children don't really get affected. Why don't we intentionally expose them to get to herd immunity? What would you have said to me?
Well, I think when you say intentionally exposed, that sounds
that,
but I know what you mean. But you see, if you say that, then you're thought to be, that's really hazardous. But I think just exposed by their normal activities, just by being children, meeting their friends, going to school, the things that children should be doing. And I don't think they would have come to any more harm. And I think we would have got through the pandemic probably more quickly than we have. I think that there was a huge fear from the teachers' unions that they would be put at risk by the children. But actually the evidence for that isn't good. There was a very interesting study, well, there's studies by occupation, both from Norway and from the UK, showing that you were less likely to get serious COVID if you were a teacher than other professions. So that was interesting. And there was one from Scotland where healthcare workers, they looked at whether they'd got children at home. And if you lived in a household with primary school age children, you were more likely to get COVID, well, SARS-CoV-2 infection, but you were less likely to need hospitalization or let alone intensive care or to die. They were significantly better off if they were mixing with children. And that fits with my experience as a pediatrician. You know, I was meeting kids with snotty noses and gastroenteritis every day of the week. But yes, you very quickly, your whole immune system was just kept always nicely topped up and boosted and ready to fight off whatever came.
And so when we reached the point where we had started to get the vaccines coming on board, which would be about late December, at that time, did you have any thoughts that children would become involved in this program?
No. I was assuming this was going to be, I remember Patrick Vallance in one of the press conferences saying that if we vaccinated all the over 50s and everybody with health vulnerabilities, then that would have accounted for more than 98% of the deaths in the first wave. And as far as I know, that was the aim. And that's what Kate Bingham, the vaccine czar was saying. They were obviously giving it to some younger people because they were giving it to healthcare and social care workers. But they were not, and Matt Hancock was very clear this would not be a vaccine for children. And I think the first point at which I thought this is a little bit odd was when I actually saw an advert on our Thames London News one evening for children to sign up for the Oxford AstraZeneca children's trial. And at that stage, we'd got no adult safety data. And I thought, what on earth is going on here? And I emailed Andrew Pollard, who I kind of know vaguely because I've worked in the same region and I've referred him patients in the past. And he emailed me back within the hour saying, oh, hi, Ros. Yes, you're absolutely right. We don't know it's safe. That's why we're doing the study. And I spoke to him in a Zoom call in which he was very clear this was just a small pilot study. And if it seemed that children needed the vaccine and if they mounted a good immune response, which of course they did, why wouldn't they? Then they would do a properly powered full-size study, and that there was no way this vaccine would be going out to children within the year. I mean, that was in sort of spring 2021.
So could you clarify who Andrew Pollard is?
Yes, he's he's chairman of the JCVI, and he's the senior investigator for the Oxford AstraZeneca trials.
I see. So very early on, there seemed to be a push towards getting children. And it doesn't seem, did they at any point start to indicate why there was a change in direction at that point?
I wouldn't say so, really. No, I think there was a feeling that it was just being pushed. There was a lot of comments last summer from people saying, oh, you know, as soon as we finish the rollout for adults, we need to go straight to children. I mean, all the way along the line, once we got to under 50s, it had to go to under 40s. It was always, there was this race. I can remember Sajid Javid saying, we're going to hit the ground running. This was last summer when the MHRA gave temporary use authorization for this vaccine for children for 12 to 15s in June of 2021. But it wasn't until mid-July, about 6 weeks later, that the JCVI said, actually, we don't think it's appropriate. The balance of benefit and risk is too close to call, and it's not suitable for a mass rollout to healthy children. It was obviously already by then authorized for children with major comorbidities. And that's different. I'm not talking here about children who've got huge risk factors for COVID.
So we're going to
come to about healthy children, and the JCVI didn't want to do it. But I think the politicians were quite disappointed, because I think Sajid Javid was planning to get the first dose rolled out in the summer term, and then they would have had the second dose when they came back in September. So the JCVI had 3 more meetings, and each time they said no. They got pushed to saying, okay, 16 and 17-year-olds, but they still said no for 12 to 15s. And there was another emergency meeting called at the request of the CMO, only 2 days after one press statement. They had to go back and look again at why they'd said no. And then by September, they were having meetings with cardiologists in the States about the risks of myocarditis, and they still said no. But at that point, they slightly copped out, because they said, well, in terms of health benefit, there isn't a real health benefit to 12 to 15s being vaccinated. But if it could keep schools open, maybe the CMOs would like to look at that. And that's when the CMOs took on this completely different remit of saying, oh, well, we'll keep the schools open. Well, that hasn't been a great success, has it?
Before we get into the JCVI, I just wanted to clarify, because early in the year, you got involved with the HART group. Can you tell us a little bit about what that is and why you did that at that point?
Yes, I joined up with them in January 2021, just after they founded. They're a group of scientists and academics, medics. It's a very broad disciplinary bunch. There's about 40 of us, including a professor of ethics, professor of risk management, a professor of medical microbiology, pathology. I'm a pediatrician on it. It's quite a broad group. And I think we were concerned that a lot of the information and advice the government were getting from SAGE was very narrow in its focus. They seemed to have a lot of mathematical modelers on the team. They didn't have an immunologist that we could see, which I think would be fundamental really to this. They didn't seem to have a lot of experienced public health. We've got a retired public health consultant in the team. So the idea was to provide a kind of what you might call the red team, when you have to have an alternative look at all the data, just to make quite sure that you're getting a balanced view of the possible management.
And so you guys came together and you started to position that you were looking at the data, looking at the science from a different viewpoint.
Yes.
Did you get any kind of ear to the government, or were you ignored?
Well, not to the government. Yeah, I would say we were ignored. We got quite a number of MPs. I mean, we were initially sending out weekly bulletins to all the MPs in the country. We started off with a sort of in March with a big position statement with about 15 different papers in it, looking at the harms to children, we had professors of psychology too, looking at the impacts on children's mental health, etc. So it was at that stage, it was mostly about looking at lockdowns and various other measures, particularly masks and so on. And we've got 60 or 70 MPs who quite regularly read our bulletins, and we've got quite a wider broad readership. But in terms of central government, no, I think it's been very disappointing.
And so can you explain why or let me put it another way, would the government have just considered you guys just another fringe group that has an opinion and not necessarily anything that they should take advice from? Would that be an unreasonable position for the government?
I think that's probably the position they're taking. Same with, I'll come on to, but obviously I've had a group that have been writing letters about the children's vaccines to the MHRA and the JCVI, and we've had one or two replies, but mostly they're ignored. But this is quite a broad group. We've got, several professors in the group, and I think it's very unfortunate, because to my mind, science isn't science if you can't debate. And I think it becomes dogma. And one of the really, to me, serious aspects of the whole pandemic management has been censorship. There is undoubtedly massive censorship. I've got people who've signed letters of mine who've then lost their job over it. And that's quite an undertaking, just for signing a letter. All our letters, everything we do from HART is all evidence-based, it's all referenced, that you can click on everything, all hyperlinks to the different references we've used. We've got a huge body of articles that we're using.
So let me ask you a personal question on this, Ros, which is that you are speaking about this from a position of being retired.
Yeah.
If you were in full-time employment in your district hospital in the middle of your career as a consultant, and you thought these things, would you have spoken about it?
I hope so. I hope I would have been brave enough to do so. I think I would, but I can't say that for sure. I haven't been in that position. Certainly if I was senior in my career, towards the end of my career, I have no doubt I would have been speaking out loud and clear if I'd still been running our local paediatric department.
And so
a lot of my colleagues in my age group would say the same.
And so therefore, do you think that some of your colleagues in terms of pediatrics who are seeing this, because some of them must be concerned, not all of them, some would be completely agreeing with the direction.
Yeah.
But for the ones who were concerned, do you think that it would have been worth it to speak out? Because it could only come with pain.
I think it's difficult, and I think more people are speaking out now. We've had a number of people. You just take somebody like Steve James, who cornered Sajid Javid brilliantly when the press all there, and he's had quite a lot of coverage since. There's a nice GP, David Cartland, who's actually resigned from his post because he felt he just could not carry on in all conscience with what he was being expected to do. I think there's also been a lot of pushback. I think the academic departments, I hadn't realised until I've learned a hell of a lot in the last 18 months, I can tell you. I thought, for example, that the MHRA was a quango paid for by taxpayers' money. But it's not really. It was, I think, and I think probably 20 years or so ago, it seemed not unreasonable that this was quite expensive to run this, and the drug companies were all making lots of profits. So why not make the drug companies pay for the service of having their drugs investigated and licensed? But the problem with that is you do then get a conflict of interest. And I think the same has happened within academia, is that most university departments in, medicine, bio, tech and so on, have huge amounts of funding from the drug companies. And that, one of the people who lost his job over signing one of my letters, he had a major research department, and his prof came to him and said, if you carry on with doing the sort of research you're doing, we've been told we'll lose grants. So he was asked to leave. He wasn't sacked, but he was in effect said, if you stay, you have to stop doing this angle to your work because we won't get any grants for anything else.
That's pretty serious.
And I think that's really serious.
So,
I know of other people who've had a lot of pressure put on them. I had one very nice surgeon who I couldn't do a talk radio I'd been asked to, and he did one. And he talked all about informed consent, just because that, again, is something we're not really seeing, is that proper detailed informed consent you have before an operation. They tell you what are the common risks, what are the rare risks, what would happen if you don't have this operation, and so on. And it's all designed for you as an individual. But with the vaccine, it's just as simple, it's safe and effective. It takes no account of the different balance of risks for different age groups, for example. So he just explained all that. He got called in by his CEO to say, because somebody had obviously seen it on, I don't know if it got onto Twitter or what, but somebody reported him, and he was in the end told he could carry on, but he had to take off the word consultant on all the letters he signed, as if that would just sort of downgrade his credibility. He is still a consultant, but he's not allowed to say so on the letters. It's just petty.
And so this is very, very concerning, because the general public has the perception that the medical fraternity is completely in agreement with everything that is happening because they're silent about it.
Yeah.
Would you say that it probably indicates that people are silent because they are afraid?
I do think so, yes. I think one of the things, if you look around the recent NHS vaccine mandates, the whole population as a whole, I mean, certainly the over 70s are 95% vaccinated, but as you go down the age groups, it's younger and younger, which makes sense, doesn't it? If you're at a lower risk, you'd be less likely to take the vaccine. And for health workers, it's been this constant push about how irresponsible, but of course, most of them have had it. And if you worked all through that first year, putting, as you say, your life on the line because you didn't know how dangerous it was going to be or not, and you went to work and you caught COVID and you survived it, and you've now got good natural immunity, and then you're looking after people coming in with vaccine injuries, why would you want to go and get this vaccine? Particularly if you've already had COVID, it becomes all risk and no benefit. And I think if anybody if Sajid Javid wanted to really ask health workers why they weren't doing it, and if you look, the proportion of people who are working in hospital who were not vaccinated was higher. And particularly doctors have got the highest lack of vaccination. And I think that's because they've been doing their reading.
It's fascinating. Okay, so let's just dig into a little bit about the reality of what you're challenging, because actually before we dig into it, I'm going to put another challenge to you, Ros. Public health needs consistent messaging. They don't need people questioning the value of a procedure. And if you go back to what happened with MMR and Dr. Wakefield and the damage that could have been done to the public health programs, do you think it's unreasonable for public health and governments to say, please don't talk about this if you are not in a position that you're making senior or major decisions?
I can see where you're coming from, Philip, with that. But I think the trouble is it's quite dangerous if you can't make questions. Now, when Andrew Wakefield questioned something, which I think he felt obliged to do, whether he was right or wrong in his conclusions is a different matter. But for him to have remained silent, if he really felt there was a risk, he had a duty to speak out. And if you look at the GMC guidance for good practice, one of the things in it is that you have an obligation to say if you think patients are being put at harm. And we're in a situation, I mean, I just think back to the days, you know, there's stuff going around schools, educational input about the vaccines, which have pictures of children with smallpox and children in calipers following polio. And then the very next slide is, when can I have my COVID vaccine? Now, that's deceitful to be implying that COVID is on a par with polio and smallpox. Now, you know, when my parents were wondering whether to give me polio vaccination, they just could look round the class at school. I had a child in my Sunday school class who got polio and is in calipers. You know, we didn't need to be bribed, given pizzas, given rollout of vaccines in nightclubs and football stadia, where they were giving free tickets to the football to the first 1,000 people to turn up. The push for this, the amount of money that's been thrown into advertising, every time you put on your car radio, there's another advert to go and get your booster. I find this very odd. I've never come across a drug before that was so effective that people had to be coerced. And, you know, in many countries, I mean, Austria were about to send their citizens to prison for not being vaccinated. The entire population of Austria will have to have the vaccine. And then they was due to come in on the 15th of February, but they've actually moved it to the 15th of March because they've still got so many people unvaccinated that it was unworkable. But they were going to face a €300 fine the first day you went out and a €3,000 fine, you know, cumulatively over the next, every time you went out of your house if you weren't vaccinated, to the point where if you couldn't pay the fines, you could do a year in prison. And this is for a vaccine which is still in the experimental phase. And I think we shouldn't lose sight of that. When you say experimental, you're thought to be a conspiracy theorist. I've spent my entire career promoting vaccination for children, but I wouldn't promote a vaccine which had no long-term safety data. And I think it's different. If you're in your 70s and you're at risk from COVID, then you're prepared to take that. It's all about balance of benefit and risk. So if you've got a high risk from COVID and a low risk from the vaccine, then you might think, well, I don't mind about long-term risks because I want to get through the next couple of winters. Mm-hmm. But if you're a child and your risks low, down and down and down to where they're, and then also the vaccines are perversely actually slightly more hazardous in younger than older people, probably because they're mediated by the immune system. So if you've got a healthy immune system, you're more likely to get vaccine injury, although you're less likely to be upset by COVID. So then you get to the point where, hang on, isn't the cure going to be worse than the disease? Is this a reasonable balance? I think not.
So these are some very important points. And I want to take on one of the things that you said, because you used a word that is not liked. Well, I shouldn't say it's not liked, but is looked down upon, where you said experimental, and you mentioned the word gene. Why are you making this vaccine sound different from many of the other normal vaccines that we use and are promoted? In what way do you perceive that this is different?
It's not my perception, Philip. It is different. It is totally different. I think, and this is one of the problems. If you use the word vaccine, obviously that's very reassuring to the public because we've had vaccines for decades and they've been, you know, it takes an average of 5 to 10 years to get a vaccine to market. But the technology, once the technology is there, you could then modify it to use a different bacteria, for example, but the same principles would apply. You probably will be fine. But the mRNA technology is completely new. It's not been used in humans before. It was tried, I think there were some efforts to get a vaccine to the SARS-CoV-1 virus, which were scrapped because they had such a high level of deaths in the ferrets that they were testing against. But the problem, I think there's two different problems. One is, for example, just the dosage. If you say give somebody a vaccine for hepatitis, let's say, there is 10 nanograms of hepatitis virus antigen in the bottle, and that's in the dose. But for the mRNA, it's 10 nanograms of a gene, and that is then given to you inside a little lipid nanoparticle. It gets into your cells, and it tells your cells to make the spike protein from the coronavirus. And then you make the spike protein, to which you then make the antibodies. But they've no idea how much spike protein individuals will make. So if I get a hepatitis vaccine, I know I'm being given 10 nanograms of hepatitis antigen, but I have no idea how much coronavirus antigen I'm being given. And also the technology involved, the nanoparticles, they haven't even done thorough biodistribution studies. We got hold of one from Pfizer in Japan, and this was just on rats and mice, but they found that, and this wasn't for the whole vaccine. If you do different components, in the past, each one had to be separately tested, and then you had to test the whole thing together. But so the lipid nanoparticles can be seen to be actually concentrating in the testis and the ovary, even a week after the injection. We've been told, I've heard people on television saying, oh, you only have the injection in the muscle and it's all gone within the week. Well, again, quite recently, somebody's done a study showing that you can still find the spike protein, I think, 60 days later in regional lymph nodes, in all sorts of places. It's been seen in heart muscle at post-mortem.
But a lot of this...
we don't know enough about it, is really what I'm saying. This is new. And if you've got a big threat, then you're prepared to take the risks of something new with still lots of unknowns. But if people tell you they know this is safe, and they'll say it so convincingly, I would say to you, they don't know that. They can hope it's safe. And I'm not saying that it will have loads and loads of long-term side effects. I'm not, but I'm simply saying we do not know. And so if you're a parent of a child who's at vanishingly low risk of COVID, and anyway they've had it, then why would you risk giving them something that is so unknown?
So, it's a good opportunity for us to look at what the JCVI was saying in terms of their statements for 5 to 11-year-olds. So this is from the UK gov.uk.
Yeah.
They published this on the 16th of February, so not too long ago. So they were looking at certain clinical risk groups of children, and I'm just going to roll down.
Yes, can you stop, actually? Can you just go back?
Yeah.
If you just stop at advice, that paragraph on advice, just go just like there. Perfect.
Yeah.
The intention of this offer is to increase the immunity of vaccinated individuals against severe COVID-19 in advance of a potential future wave. So they're not even saying that this is going to help them with the current COVID virus.
So
they're talking
yes,
about some potential future wave.
So,
and then you go on down it, and it's full of the most extraordinary statements. It's full of statements saying that the impact is highly uncertain, is I read in one place. In another place it said indeterminate. Now, if you think the impact is highly uncertain, why would you be recommending this?
So if you go down to their detailed considerations, they considered evidence on the potential direct health benefits and harms. So they did consider the potential harms. They were looking at the risks, not the risks, but the impact on education and also wider anticipated opportunity cost. Not sure what that means. And so they were also concerned about children missing school and the fact that you can protect children from being away from school by them being vaccinated, you know, and yes.
Just pause there, because in the summer, if you remember, when they were talking about 12 to 15-year-olds, they kept saying there was no health benefit. And that was when Delta was around, forget about Omicron. And then it was suggested that it might be good for schools. Now, the main reason that children have been missing school isn't because of COVID, it's because of the policy which said that if one child in your class has COVID, you all have to go home. So over all the last year, we kept asking how many of the children who got sent home actually got COVID in the next 10 days? Did they need to be sent home at all? And in the end, come the last day of the term in July last year, last day of term, we got a reply suddenly which said 1.8% of all the children who'd been sent home because of a contact got COVID in the next 10 days. They couldn't say they'd caught it at school. It could be that their parents had brought it back from working, out of the house. Could have been from anywhere, but that was the maximum. And then they also said in August last year that they were going to change the rules about isolation. So they took away this thing that said schools had to send children home and said that in future, actually, if you were under 18, you didn't have to self-isolate, and it would be up to track and trace to tell families if they were in, serious household contact. And even now, I think if you're a child, you don't have to isolate, even if your parent has got COVID. So in fact, most of the disruption could have ended. It hasn't ended because schools have carried on exactly as before, sending home swathes of children, as far as I can see. But we're now in a situation where 85% of primary schools are estimated to have had COVID. So why is it going to go on disrupting? They also, when they passed this to the CMOs to look at in September last year, they did a modelling on days saved by vaccinating. And A, it didn't take into account the fact that lots of children had already had COVID. So it was assuming that all the children were at risk. But B, it took no account of time lost by the vaccination or vaccination injuries. So they calculated, it came out as an average of 15 minutes per child that was going to be saved by not catching COVID at school. Well, 15 minutes is the time you have to wait in the school hall after your Pfizer jab. You take a lot more than 15 minutes by the time you've gone, waited, etc. You'll probably have an hour out of class. It takes no account of the fact that, for example, for even the 5 to 11s that we're now talking about, in the US, between 8 to 10% of children have had at least one day off school because of vaccine side effects. Well, that's quite a big amount. And if you're talking about the psychological impact of time off school, well, they should have thought about other ways of dealing with that than giving them some vaccine to protect their mental health. If you had a child have serious myocarditis and be airlifted off the sports ground 2 days after the vaccine, that wouldn't do wonders for your mental health.
But myocarditis, it's not a huge risk, is it? When we look at the numbers with regards to children, a few children can get it, but it's not frightening. The CDC weren't worried. The MHRA or JCVI weren't worried. Why should anybody else be worried about myocarditis?
Yes, I think that's a very interesting question. I did a Zoom call with the team in Israel. You've got some data, I think, that I sent you. They had published that 1 in 6,000 of their 16 to 19-year-olds were getting myocarditis after the second dose of Pfizer. That's a big number when we're talking about 1 in a million risk of dying of COVID for this age group. You have to remember that. It's such a rare thing to die, for a child to die of COVID. And so when they sent me the data, they said something about, I'll send you the group stuff we sent to the other English group. Well, that turned out to be the JCVI. So if you look at this, I'm sorry about it being in Hebrew, but the numbers are still numbers. So the top line is 16 to 19-year-olds, and that figure there is the risk to boys after their second dose. So 1 in 6,000 of them were getting myocarditis after the second dose of Pfizer. But if you go down the age ranges, you'll see that at the bottom of that same column, you're down to 1 in 72,000 if you are over 30. So between the under 20s and the over 30s, it's 10-fold more likely that you'll get myocarditis. The latest figures I've seen have come from Hong Kong, and they have done, because they were looking for this from the beginning of the rollout in a systematic way. We don't have a systematic, we have just yellow cards sent at random as far as I can see. But they have looked and they've come up with 1 in 2,680. Well, that is, it's technically rare, but people are saying it's extremely rare. It's not extremely rare. And also, and in fact, what they've done in Hong Kong is because of that, they discontinued giving a second dose, because it seems to be particularly after the second dose that you get into trouble. And they said they were going to mimic the service in Britain by going for only a single dose. But meanwhile here, because we don't seem to have had enough side effects from 1 dose, we've suddenly said, let's give them 2 doses. And I can tell you there will be more myocarditis over the next few weeks if all these 12 to 15-year-olds parents go and get their second dose for them. And I think that's tragic because it's unnecessary.
So here's an interesting question that Susan, I'd interviewed Susan recently. She's a pharmaceutical regulator.
Mm,
And so she has said it would be interesting to know how many of the regulatory staffers sent their kids for the shot. That would tell you
mm,
quite a lot. Because, yes, I think from a regulatory point of view, they do know that there are risks and there needs to be quite a bit of caution. I bring up this case here, and I couldn't quite get the full paper, but this was, I think, in the US recently, the histopathological examination of two
mm,
adolescents who had quite severe reactions after the second dose. And I think I'd looked at the paper, and one of the things that stood out to me was that it wasn't just there was myocarditis, but there was evidence of fibrosis in the muscle,
mm,
which would suggest that the inflammatory process had occurred before they then had the second dose and then died, because they died
mm.
within about 4 days. So it can be serious, but I guess the counter argument would still be it is still relatively rare. Should people be concerned enough because it is going to impact the rollout of vaccines in the pandemic?
Well, if this had been taken seriously properly, it wouldn't need to impact the rollout because it wouldn't need people having to shout from the rooftops to say this. Because what they could have done is not rolled it out to children in the first place. And we don't need it to be rolled out to children. Children do not need this vaccine, so why put them at risk? And if they have some deaths from myocarditis, it will really impact on vaccine confidence for lots of vaccines. I think that would be very unfortunate. If you were to talk about, they say, oh, it's uncommon, which it is, if we're talking about 1 in 2,000, 1 in 2,500, that comes into the category of rare. But if you look at the impact, they say, oh, it's mild, it gets better in a couple of days. I was in a Zoom call with a team in the States who'd looked at cardiac magnetic resonance imaging, and they found 90% of the children, although their symptoms had gone away, they were not severely ill. When they did the MRI scans, they found evidence of swelling in the heart muscle and scarring. And they wanted to follow them
90%.
up. Sorry?
Did you just say 90%?
90%, well, 89%, sorry, I'll be strictly accurate. 89% of them had evidence of scarring. And in the JCVI minutes, because they've had meetings with those cardiologists, I've also been in Zoom calls with the same cardiologists, and who were extremely helpful. And if you look at the minutes of the JCVI meetings with the cardiologists, they were very concerned. The JCVI team are saying, they said back in July and in September that they wanted to wait until follow-up studies have been done on those children. I mean, we've been criticised at being late into vaccinating kids in the UK compared with other countries. But to my mind, the one bonus of being late is, I don't want Israeli and American children to be guinea pigs, but if they are getting the vaccine, shouldn't we surely wait for their results in detail? And there they are, they're following these kids up with a repeat MRI after 3 months. It's really going to be important to know whether those changes have gone. And we've seen children who've got symptoms ongoing after 6 months. They're still getting breathless and chest pain when they exert themselves. In Hong Kong, I was interested to see that they have actually given leaflets out because they were aware of this, and they've advised children there to do no strenuous exercise for a week after vaccination. Well, if we were told children here they weren't allowed to exercise for a week after vaccination, it would really raise parental awareness that this isn't a terribly safe vaccine.
So I need to clarify that point that you just said. You said that 89%
Yes.
of cardiac MRIs. Where is that? That could not have been published.
Oh, it is. Yeah, no, it's absolutely published. I mean, I only got hold of the group because I'd read the publication. And when I saw that the JCVI had been in conference calls with cardiologists in the States, I thought, well, I know who that's got to be because it's a big multi-center study, 63 children in 40 different centers in the States.
So
And
was
there's
it
been another one,
63?
there have been similar findings from France. There's been another American study as well. There are 3 publications.
So let me clarify that. So what you're saying is that in the patients or in the children who had myocarditis, when they scanned them 3
Yeah.
months later, 90% of them still had
No, not
ongoing.
3 months later. That's the problem. We have been too hasty. We're not waiting for the follow-up. So these are in the immediate post, they've come into hospital with chest pain and, very raised cardiac enzymes. And then they're getting better. But because it was not because these children were particularly sick, but because this was a new condition and these were big teaching hospitals with MRI facilities, they did the MRI scans on them. When I talked to them, they were really surprised at the findings because they had also scanned some children who'd there's a nasty post-inflammatory syndrome that can occur with COVID. It's rare, and children have seemed to make a very good recovery from it. But they'd scanned some of those children, and the findings were much milder in those children who'd been in intensive care. They'd been really sick. But these children had come in with a couple of days of chest pain, and then they got better, and they were home within 3 days. But their scans were abnormal, and they wanted to follow them. And they are in the process of following them all up, and maybe they'll publish and they'll say they're all fine. But I would be very worried because viral myocarditis certainly is a risk factor for late, cardiac failure and arrhythmias and so on. And I think I just think we've lost sight of the first do no harm principle. We're always wanting to do something. So if there's a panic on, you think I must do something. Sometimes it's better to just sit back and think and just give it a bit more time, particularly for children, because my point is that for older adults who were genuinely at risk, it's very different. I think the idea of all the money that got put into vaccine technology to try and find a vaccine quickly, that was very laudable. But the fact that it's a vaccine which, all drugs have side effects. And this, as vaccines go, I wouldn't say rated very well in terms of safety. If you look at the VAERS, which is the American, like the yellow card system we have here, and the same with the yellow cards, the number of adverse event reports coming in, particularly the number of deaths, are higher. In the last year, 2021, the COVID vaccine reports of death occurring within, 28 days of the vaccine, and mostly much sooner than that. But they're the same as all the vaccines put together over the preceding 20 years in VAERS. So it's not a terribly great vaccine. But if you've got a high risk from this disease, well, then maybe that's a balance. But for children who are not at risk, this has never been an emergency for children. So why are we using emergency legislation? These are not licensed products. They're still under a so-called emergency use authorization.
So if you were therefore the fly on the wall watching these meetings, what do you think? Because you're right, they were very hesitant initially. They were following the instinct that you described. Why change their position?
I wish I knew. I think they've had. I'm sure there's been pressure on them, but it's hard to verify that. I'm speculating here, and speculation isn't what I want to do.
Mm-hmm. Yeah, because it is a challenging scenario. You have governments pressuring you; they want to do things for whatever reason. You have pharmaceutical companies that could be pressuring people because, as you said, they're financial conflicts of interests. And it can influence decisions that are quite tight, like this one here was, it wasn't clear cut, absolutely not. There was some consideration that they would do it. And then suddenly, if you are close to balancing point, anything can tip you one way or the other. So it would be difficult for them.
I think that's right, I'm sure. And I think one of the things, I was talking earlier on about censorship, and I think that's been very worrying. But one of the things it certainly brought to my attention is the whole problem with conflict of interest. It seems that, I was on the school governors. If you declared an conflict of interest, you were excluded from the room for the thing they were then discussing. If it was a building extension and your brother-in-law was a builder who'd put in a bid, you didn't stay and discuss it. You went out while they discussed that and made the decision. But here, the conflicts of interest on the JCVI, they'll all list them, but it doesn't mean they leave the room because they've all got get grants from drug companies. It's difficult. And the chap who designed the yellow cards in the first place, a chap called Bill Inman, I think, was after thalidomide, when it was very obvious that there needed to be a system for new drugs that would quickly realize if something was going wrong. And he introduced the system, but at the time he said that the most important thing was that they had to completely separate the drug industry from the regulatory industry. And I think that's one separation that has to take place if there's a later inquiry into how we do things better. And also there has to be a separation, I think, between the regulatory authority and the subsequent vigilance and monitoring. Because again, what's happened here is that the pharmaceutical industry, their post-marketing surveillance has been very haphazard too. So, if you buy a book on Amazon, you've got a thing after an hour after it's been delivered saying, what did you think of the delivery system? And by the next day, they want to know whether you've enjoyed the book. But here we are. Most patients wouldn't know that the yellow card system exists. Doctors who are trying to fill it in are being discouraged by their peers from doing so. Oh, why are you filling that in? But, you don't know that this stroke that this patient's come in with is due to the vaccine, although the vaccine was 2 days ago. But you don't have to know what you're meant to do. There's a system called the black triangles. Well, you'll be familiar with this, obviously, but there's a black triangle in the formulary, which is that all new drugs for 2 years, you're meant to report absolutely everything. And it's then up to the regulators, in this case, the MHRA, to then look at all that information coming in and work out whether there's a signal or not. And it's not saying that this is cause and effect, but it's saying if if it's a common event, and then you suddenly see that even a common event has suddenly become 10 times more common. And if you look back, for example, at the blood clotting with AstraZeneca, I was talking to one of my colleagues and she was saying, oh, there's only been 10 cases and we've given out 10 million doses. And we were being told it's not a problem. But it took Scandinavians to say, hang on, it's predominantly young women. Now, at that stage, most of the people receiving the vaccine were the elderly. But of course, the young ones were the healthcare workers. And then you realized that actually it was quite significant signal if you did a proper age stratification. And then you found that countries were saying they wouldn't give AstraZeneca to under 50s. We went for under 40s, I think. And the same has happened in a different direction with the myocarditis signal for Pfizer, is that, again, it's the youngsters that are getting it. And you keep saying, oh, it's safe and effective, as if it's all the same for everybody. And it's not. And particularly, I think if you were looking, it's been quite often, there's a paper from Oxford that's been misquoted a lot, saying that you get more myocarditis after COVID than you do after vaccination. But in the paper, they divided it into 2 age groups, over 40s and under 40s. And actually for the under 40s, it was very clear that myocarditis was commoner after vaccination than after COVID. And for the elderly, it was commoner after COVID than after vaccination, which comes back to my point. Informed consent has to be for giving the information that's relevant to the person you're consenting. So saying safe and effective is not informed consent.
So how could we, or let me put it another way, because if the trends that we are seeing are correct, we could see a lot of injuries coming up later down the line. And the question is going to be asked, how could that have been missed? And any thoughts?
Well, I think one of the other things which has been, again, I perhaps hadn't thought about, but one of the things is that in most drug trials, you're expected to do all-cause mortality is the gold standard. And it's also on a so-called intention to treat basis. So at the beginning, you take half your patients are randomized to get the test drug, and the other half are going to get a placebo and just be the blank controls. And then you follow them all up. Now, if some of them leave the trial for whatever reason, you still keep them in that final analysis in the group they were intended to be in. So, for example, in the Pfizer trials, anybody who got COVID within the first 3 weeks of vaccination was removed from the vaccine arm of the trial. They just dropped. And if you look at the data that defines admissions to hospital whether you're vaccinated or unvaccinated, all of that data, you only count as vaccinated when you're more than 3 weeks from vaccination. And I can see the argument for that. It's thinking, well, unless your immune system's had time to work, it's not fair to say that you're vaccinated. But actually, if it comes to looking for side effects, you have to include everything, because you're missing out the period when most of the side effects will happen. So if you look at all-cause mortality, that, to my mind, is the only real test. And, there'd be, for example, you might take a hypertension drug to lower your blood pressure. You could have a fantastic drug which lowered your blood pressure very efficiently and meant you had less heart attacks and strokes. But if it was so efficient that actually people kept fainting and falling over and having head injuries and broken hips, and they died of those instead, then it wouldn't be a very good drug. So we really do need to look properly at the all-cause mortality for all of these vaccines.
So these are some very, very important points, Ross. And I'm reflecting on, I'm genuinely trying to understand why. And it was a similar discussion with Susan, and actually Susan luckily is on the call. She's made this point here. So typically vaccines are given by the child's physician, who will give advice about risk benefit and monitor the child for any conditions in the future. In this pandemic, vaccines are given in clinics, and so therefore you have a disconnect between the physician and the parent child. And this is a very unusual situation.
Yeah.
And it leads us, therefore, to potentially making errors that we wouldn't have done otherwise. Was there any way that you could have seen, because there was a panic, there was a fear, or let me ask you the question I genuinely ask other people. The initial part of the vaccine rollout was for the vulnerable. When did we transition to herd immunity for the population? Can you remember?
Well, I suppose it was about March, April of last year. I mean, it was interesting because all those dates, we had a whole load of dates for when we were going back to normal, if you remember. And they were predicated around, first it was going to be that all the over 50s, well, first they were going to say the schools could go back when all the over 70s had been vaccinated, I think, because they were the most vulnerable. And in with those came people with severe medical vulnerabilities. And then it got to say, oh, well, we shouldn't. And they delayed the schools going back from the original date that was given, because then they said, oh, they need another 3 weeks for the vaccine to work. And then it was shifted to say, oh, well, we need to get the over 50s vaccinated. And it was after that. So I suppose it was getting through to April, May. They started just going on down and down the age groups. And I think the point that Susan's just made about the venue for the vaccines is very important. I've got a friend who's been doing, again, he was retired and he went back to help and work in a vaccine clinic. And I was talking to him about myocarditis and he didn't know anything about it. And I thought, this is very worrying, because he is now vaccinating children and teenagers. Who's doing the informed consent? He had had no information sent to him about myocarditis.
Really?
Now, we seem to have a lower rate here. Or that's so the government or the JCVI keeps saying. But I don't know if that's just because we're not looking for it. And for example, Israel, where the signal was first spotted, when they first saw an increase in myocarditis, because they were doing the proper phase 4 trials for Pfizer, in effect. They've been monitoring their population much more closely. And as soon as they saw that signal, I was having talked to these guys on Zoom, they said that they'd sent a letter to all the pediatric consultants, all the emergency care physicians, all the GPs, and cardiologists and so on, to tell them about this and make sure they looked out for it and make sure you report it. And I don't get the impression that that's happened here at all, because they, as I say, I've got friends doing vaccination clinics, and they don't seem to know anything about the risk of myocarditis in young adults, particularly young boys having second dose. And I know of people who have been offered a second dose despite having had some myocarditis after the first dose, and they're told, oh, don't worry, you still should go along and have your second dose. People who've had allergic reactions to the first dose, and they've still been told to get a second dose. And I had somebody write into HART who was a retired health worker, but she'd had major anaphylaxis to both the components of both Pfizer and AstraZeneca to the point where she carries an EpiPen. She's been strongly advised not to get the vaccine by her GP. And so she thought, fine. And when she came to get her exemption form, they had to send the exemption form back to the GP. And he sort of said, oh, I can't sign that. And the next thing she knew, she'd been referred to an immunologist. She thought they were going to help sort out her allergies. But actually, they said, oh, I gather you're being referred so we can do the vaccine in hospital under supervision. So instead of giving her an exemption, which is what she should have had, because she's had major life-threatening anaphylaxis, they're saying, oh, let's give you the vaccine in hospital with a drip running and adrenaline on the side, just in case. So in other words, they've acknowledged fully that this is dangerous and they can't do it in the GP surgery. So who gets the vaccine exemptions?
Yeah. So here's a question here. What does that say about the parents? How much evidence do they need? Who is responsible here?
Well, I think this is a real problem, because if you look at the information that's gone out for the 12 to 17s, it's been very biased, I would say. It's put across one thing which we haven't really talked about, which is that children will be doing this for their vulnerable relatives, because I think most parents realize that it's not for the children themselves. But of course, that's not really going to work, because as we've seen, this is a very leaky vaccine. And so we know that people who are fully vaccinated, triple vaccinated, are still catching and passing COVID on, which is okay because they've got protection against serious illness and death from their vaccinations. But so if you're giving it to your child to help them protect other people, that's not a good reason for doing it. And people are also saying, oh, they need it to go on holiday, or parents who are working, they need it because if their children get sent home from school, they can't, they can't be off work. But these are all very odd reasons to be considering giving your child a drug with very poor long-term safety data. So I would say to parents, honestly, I would not go there. I just wouldn't.
These are very important. Why is it that nobody else would be willing to have these kind of very frank, candid discussions? Because the truth is that if a parent hears this, you're technically making them hesitant. So from a public health point of view, they're saying, listen, we're not happy with that. Why are you making parents hesitant to take a vaccine for which, yes, there are a few minor myocarditis side effects, but on balance, it's safe? Because that's effectively what they've said.
But I don't think that's the case. And that's my problem. I can't not speak out about something which I think is fundamentally wrong. I think if your child has had COVID, they have really good natural immunity. In the first year, there was a lot of rubbishing of natural immunity, but there's been loads of more studies showing that children particularly have very good upper airway immunity. So we've been only looking at antibodies and then saying, oh, your antibodies are waning after you've had the infection, so that must mean you're at risk. But it doesn't, because your antibodies are meant to wane. You're meant to have memory cells so that if you meet this disease again, you can make new antibodies. You don't just carry them around all the time to every disease you've ever had. So there's been a lot of misinformation out there. And I think that the assumption is all the misinformation is coming from people questioning. But I think there's been a lot of misinformation coming from government spokesman saying that this is entirely safe and saying that natural immunity isn't good enough. And it is. It is absolutely good enough.
But why?
Interestingly, after SARS-CoV-1, 17 years later, at the time of SARS-CoV-2, they looked back at people who were blood donors and they got blood stored from a couple of years earlier to test them against the virus, and found quite a lot of them already seemed to have some cover against this new SARS-CoV-2. And then they discovered it's because, of course, they'd still got immunity from SARS itself, which was in 2003. So this was 17 years later. And this is a virus that we're not meant to be able to provide long-term natural immunity. Children particularly have got really good upper airway immunity, much more effective. There's been good studies showing that their upper airway immunity is more effective than that of adults.
And so how is it that they seem to have missed this important point about mucosal upper airway immunity? You're right. They keep on talking about serum or systemic immunity. This is such a basic immunology question. How does that get missed?
I don't know of an immunologist who was on the main SAGE team. There have been a lot of immunologists in other countries speaking out as well.
So we are getting this kind of advice without actually having expert immunologists involved in the decision making.
I'm not saying that, Philip, because of course they'll have a core team, and then they will go out to other people and get advice. And we can't see all of that. But I think, I don't know, I'm at a loss like you to work out why, you know, and you can say, oh, it's greed on the part of the drug companies, but you think, how greedy do you have to be? You've already made billions of pounds and dollars on rolling this out to all the adults. They're trying to roll it out to the entire world, you know, and it's also the other thing I think people forget is about the indemnity. None of these drug companies will have to pay if you have a vaccine injury. So they've all got completely unlimited indemnity provided by governments. And that's because it's an emergency. The AstraZeneca chairman actually said, well, you can't, a CEO said, well, you can't expect us to provide indemnity when we don't know whether there'll be side effects 4 years down the line. He's quoted saying that. So that's why the governments had to, if they wanted to use this for an emergency, they have to provide cover. And once it's fully licensed, as far as I understand, then drug companies can be asked to provide indemnity. But at the moment, if you get this and you get a vaccine injury, you will get a maximum through the government vaccine injuries scheme, which is £125,000 if you can prove that you're more than 60% disabled. So if you lost a limb from a blood clot, you wouldn't presumably get anything at all, because you wouldn't be more than 60% disabled, would you? And if you were had a stroke and were debilitated for life, you'd still only get £125,000. Doesn't feel right.
Wow. So one of the points, as we're coming to the end here, Ros, one of the things that you had mentioned before was about some of the observations you've made with vitamin D. Some very basic public health advice seems to have gone missing.
Yeah.
What are your thoughts with regards to that?
Well, I think it's interesting because there was quite a concern in the first wave, particularly about ethnic minorities being at higher risk. And of course, that partly was emphasised by the fact that in healthcare, there are a lot of Black and Asian staff on the medical and the nursing staff. And so they were in the front line, so they were getting more exposure. And was that why they were at more risk? Or was it other factors? And the one factor that really stands out to me is vitamin D. I mean, I've worked in Slough and we've got a big Asian population, and you know, I used to see children regularly with vitamin D deficiency, and their parents. We'd have babies with fits because their mums have been so short of vitamin D during pregnancy. So it's known about, and it could have been so easily recommended. And in fact, Matt Hancock, back in summer 2020, said he was going to roll out, or autumn, he said he was going to roll out vitamin D to all the care homes because somebody mentioned that this would be good. But he never did it. And anyway, you don't need to provide it. You just need to tell the care homes, because I mean, you can buy 180 high-strength vitamin D tablets from a supermarket for a couple of pounds. You know, that's less than a cup of coffee. We'll give you a 3-month supply. So, you know, it could just have gone on the bill. It wouldn't, it just in the catering bill, it really didn't need a government program to do this. But it's not happened as far as I know. And I think the elderly, you know, are talking about ethnic minorities with dark skin, because you make vitamin D in sunshine. So that's a particular hazard. And the further north you go, the more hazardous. So if you're a Black African living in northern Scotland, you really need your vitamin D. But the same applies to the elderly. They are particularly vitamin D deficient, again, probably because they're not going out very much and their diet may be more poor, and your immunity wanes as you get older. And part of that could be greatly helped by vitamin D supplements. And most of the people I know, I mean, apparently Anthony Fauci takes 5,000 units a day, but the nice guidance is still only for 400 units. But he doesn't tell anybody else about it.
Listen, Ros, I tell you what, I appreciate just how open and how candid you have been with regards to sharing these thoughts, because nobody talks about these things, and therefore people are very, very poorly informed about the reality and the challenges and the decisions that parents have to make in terms of the long-term benefit and safety for their children. So really, really appreciate it. So if we were to have you to say a closing remark, Ros, what would your thought be in terms of the vaccination, specifically with children?
I would say to parents, use your own instincts. You can read so much in all directions, your mind will be, totally confused by it all. But use your own instincts. If you feel your child's not at risk from what you've seen of them and their friends, then go with your instinct. And I would also remind all our listeners that it is not for children to protect adults. It's for adults to protect children.
Absolutely. Wonderful, wonderful. Thank you very, very much, Ros. Really, really appreciate this. And we're just going to do an outro. Thank you, everyone who has been watching. I hope you found this informative, educational, and inspiring. Thank you very much again, Dr. Jones. Really appreciate you talking with us. Have a
Thank you.
great evening.